Good afternoon, everyone. I want to thank you for joining us for our training this afternoon on an organizational approach to suicide safer care with our presenter, Thomas McCary, as well as our partners, our national partners. And I definitely want to make sure that you all have a great afternoon as we all learn something new, as we get excited by the opportunities in our learning. We definitely want to, on behalf of Community Clinic Association of Los Angeles County, I want to welcome you all to this event. We are definitely excited, and we hope you are too. So without further ado, I definitely would love to make sure that Rick is on the line to join us and introduce himself, his organization, as well as our speaker. Thank you so much for joining us.
Thank you, Tracy.
Thank you, Tracy. My name is Rick Brown, and I am with the Association of Clinicians for the Underserved. Thank you all for joining us. We're extremely excited to be able to offer this training in partnership with the Community Clinic Association of Los Angeles County. And I'm also excited to introduce our presenter today, Mr. Tom McCary. Mr. McCary is a licensed mental health clinician with specialization in working with individuals who struggle with co-occurring issues. As an implementation specialist and trainer, he has brought suicide safer care trainings in person and now online to providers and primary care practices across the country. And with that, I'll turn it over to Tom.
Thank you so much, Rick. And thank you all for joining us this afternoon and morning in California. My name is Tom. And in addition to those experiences and credentials, I can also say that I'm an individual who has experienced, the loss of loved ones, friends, and family to both suicide and overdose. So this is something a topic which is very difficult, right? But also what draws me to learning about this and sharing and helping others become more skilled in how they approach and work with individuals at risk for suicide is that we as in healthcare organizations are in such a critical position to be of service and service to those we serve and also within our own organizations for our colleagues. Even as a clinician entering the field, I don't know exactly how, but I just was not anticipating having to talk so much with patients about suicide. And at first, my natural instinct is to sort of pull away and kind of magical thinking, hope that this is something that isn't a part of the daily experience. But what I realized is that just wasn't the case. There's a huge percentage of patients at the clinic I was working with in the Bronx experienced suicide. And so I kind of was at a turning point. I said, well, this is either something that I'm going to be perpetually uncomfortable with, or how do I just really throw myself into this and learn as much as I can? And I can still say today that it's not something which I enjoy, but I am much more comfortable and understand within the context of my role and how I can help people, the importance of talking about it. And I'm really honored to be able to help individuals and organizations in how they address suicide safer care. So away we go. This here is a slide, and it's called the Swiss cheese model. And it was originally developed in response to aviation and factory safety, where they were trying to find ways of reducing incidents of reducing errors. And it's been now being applied to how we set up systems, set up organizations in which it's less likely that somebody is going to fall through the cracks. And so just somehow miss all of the holes and make it through. And so within the care pathway, this starts with screening and assessment, universal screening. So many practices now are routinely asking everyone a few questions about depression, including a question about suicide. Right? So it's really the first line of defense is helping to do a universal screening and just bake that in. That is just a routine part of the workflow and for all providers. Beyond that is what happens after identifying somebody who has thoughts of suicide or is at increased risk. And this happens is collaborative safety planning, one of the first line interventions that can be applied in primary care settings, in busy environments. This is something which takes only a few minutes and can be that buffer between wherever the person's entering the system or entering and being identified, and helping them to get specialized care if they need it. Right? This is like preventing people from unnecessary hospitalization. And more specifically, we can treat thoughts of suicide specifically, and ensuring that continuity of care. Transitions of care are high-risk periods, whether this be from a higher level of care, like a hospitalization, back to outpatient care, or even within a system, changing of providers, which is something occurs so regularly, but it's known that this is actually periods of time where somebody has to retell their story, they have to regain their trust, and for so many people, those who they work with in our professional settings are some of their most closest and trusted supports, and so losing someone like that, like a provider, can be very challenging. Other transitions of care which are commonly associated with increased risk is also leaving incarceration. So returning from incarceration as being one of the highest periods of risk for individuals. I'm not going to talk too much about Zero Suicide, other than a strong endorsement that this is an organization which helps, from organizational standpoint, has developed a toolkits and resources for providers and organizations, and have a lot of the principles that we're going to talk about today laid out in a way which can be adopted at the organizational level. It's a commitment that says we're going to take on the best practices around suicide prevention. More information available. What I think is important to say is that, more and more, we are understanding, right, that we're working to provide the health and improve others. And the level of burnout, particularly getting more attention now with the demands, physical and emotional demands, and and just stresses outside of work, that often we do so at our own expense, is in a way a part of the culture of work. And sort of compiling with that increased or that vulnerability, which we oftentimes can be put into, there can be systemic barriers that either overtly or implied discourage self-care, self-help seeking, and access to care for workers and physicians in particular. So we're going to talk a little, and so we're going to talk, that's really the emphasis of what we're talking about today, is understanding some of the contributing factors, understanding some of the statistics, which helps us to say why this is such an important topic and area of change, practice change, despite it being complex and sensitive. So while suicide is the 10th leading cause of death in the United States, it's significantly higher rates among physicians and across healthcare. And across the board, people who have mental health are generally untreated or undertreated, and physicians are no exception to that. And, when we look at it in different terms, this is a statistic which really can stand out, right? That nearly every day, a physician in the United States dies by suicide. And this is just physicians, right? This is not nurse practitioners. This is not the billing department. This is not social work. This is just primary physicians. And so I think that's really a striking statistic that and why we're here today. It's also something that's not new, right? This is something that's been understood and slowly more understood, but has been a part of research and understanding for quite some time. And in a more recent study that covered several decades and different ways of examining prevalence and depression, what we know is that particularly in residency programs and early career physicians are at significantly increased risk of depression and also having a lifetime history. A more recent study looking specifically at students and residents showed that nearly a quarter of residents met criteria for depression, and nearly 3/4 met the criteria for burnout. And so this was really prevalent, yet only a small percentage of those who would most likely benefit the most received the care. And that was disproportionate to the general population. Looking more closely at suicide deaths, it was identified that this also held true in those circumstances as well, that they were less likely to be receiving care. So this is kind of the why. Why are we talking about this? And sort of the importance of it, and looking very closely at that. And what we're going to talk also is about sort of from the organizational standpoint, from an organizational approach, how do we do better? Not only how do we do better at improving or decreasing suicide within our healthcare systems, but also how we change the culture. This was a quote which I think speaks a lot. It was almost like normal news. And so that's to say that something's not right, right? If we become normalized or desensitized to loss of life by suicide, that we have gotten off track. I would like to say shockingly. I'm not sure if it is, but how shocking it is. But unfortunately, I guess I could say unfortunately. In 2019, this was one of the first studies, comprehensive studies that looked at suicide among nurses. And so while it is unfortunate, right? We just said this has been something that's been studied for 150 years among physicians. It's unfortunate that only now we're starting to look more comprehensively and carefully at how this affects different groups and roles. And again, what is not surprising, it showed that these are higher rates than normal or population, and that we're significantly at higher risk for dying by suicide. Looking more broadly at the healthcare field, these are again statistics which are showing that this is a significant discrepancy, and that while we working in healthcare, we are at higher risk but lower likelihood of care. And so why is that? What are some of the barriers that are affecting the access to mental health care across demographics, across roles? In one way, it's not totally understood, even though it's something in some ways has been looked at for a long time. In other ways, it's relatively new. Suicide in general is a very complex situation to study because of the complex nature of the risk factors and contributing factors involved. However, while we are trained to identify depression and mental health in other individuals, it is not something which is included as frequently for within the systems, within supervision, within onboarding, within school and training. And because of this culture, which is stressful and high pressure, it can also, in an effect, be normalized. That stress is normalized, and so this is again kind of setting a tone that makes it more vulnerable. That this is to be stressed and overworked is an expectation, not an abnormality. And even though working with large groups in care teams, oftentimes there can be a lack of social support. I worked in a clinic when I was in the Bronx, and I loved my colleagues. We had really great colleagues, but we had 30 minutes for lunch, and we were all in the same hallway. We had 30 minutes for lunch. The rest of the day was patient care, in and out, back and forth to the waiting room. And likely that our 30 minutes for lunch didn't line up. So here I was surrounded by really wonderful and caring people who I got to see most at meetings. But those meetings were really structured, so it was like we were passing ships in the night somehow. And so that was even in a very supportive environment where we were doing our best to look after each other. Realistically, that this is not always the case, and some environments are even competitive or really non-supportive. Right? It's a way to say it. Additionally, that there can be stigma, and that we are, never mind mental health, we primary care doctors are just less likely to get primary care themselves, right? And oftentimes citing that there's confidentiality concerns, right? This is in many communities is very small, right? We don't necessarily have the opportunity to go to care outside of the systems that we're actually providing the care in, and so and even so, it's very frequent, right, that people travel from one place to another, and so it's likely that we're to feel unsafe. And there's in surveys and assessing sort of what are some of these barriers, that mental health oftentimes is seen as a weakness. It can be shown as a fear of having even impact on medical license, adding into this, right, the risk of the correlation between mental health and substance use issues. It can become fear of repercussions, seen as a weakness. We're going to talk about some of the ways these things can change as well, right? This is not just all of this. We have to start with where we are and talk about how we can get to where we'd like to be. And so, again, this is just more reiterating that even in team, all of these things lead up to a an environment which is ripe for elevated risk and decreased care. Again, all of these things, and a bit why this is getting more in a positive way, in an unfortunate way, is getting a lot more attention since the onset of COVID, which has had profound effects on the essential workers of all varieties, and particularly within healthcare. I have a friend here. I'm working remotely, but I do go into the center sometimes. I have a close friend who works at that center, and he is living in a barn. It's a nice barn, but it's a barn with his family living in the house. His sons help take care of the property and bring him food. We're in November, right? This is a long time, and so even in the best circumstances, you can just imagine the stress. The emergency doctor of this story was a very prevalent. She was a lead ER doctor for a very prevalent hospital in New York City, who not only experienced COVID herself. This was at the height of one of the heights of the pandemic in New York City. Took her own life, and this is something which is not an isolated event. Again, and parts of this is just the physical toll, the emotional toll, and all of the decreased supports and resources that everyone in the community is experiencing, and also just, and I think feeling as if they're not being able to help, right? Feeling as much as we're trying, that this is something which is very difficult to control and help other people. So what can we do differently, right? The good news is there's lots of things, and you don't have to make it up, right? There is a roadmap for this, and organizations and models which can be adapted from, and evidence that shows this helps, that can be brought to upper management, that can be packaged in a way which is supports practice change, right? And so what we know is that not all organizations provide training on how to help and support patients with suicide, and it's less likely with staff. Organizations don't routinely work with employers to ask or train managers in how to respond. However, most organizations do, and I'm forgetting, this is a hazard vulnerability assessment, right? And so from what I understand, I've never done one of these myself, but what I understand is that this is a routine and required practice for most healthcare organizations, and are frequently somewhat not unrealistic, but less likely to happen, right? What happens if there's a tornado that hits our center? What happens if a subway car falls off the track and comes through the front door? These are what happens. All of these different situations that are run through to say, how would we respond? How can this have a space? Can a suicide of a staff person find a place in this vulnerability assessment, right? How can we make these more realistic? And how can we build this into the culture? And even when organizations do adopt practices from zero suicide, that oftentimes is limited in training and support to those who are providing direct care, which is not the embodiment of zero suicide, is that it's supposed to be organizational wide. So even when organizations are taking on best practices, sometimes it is a la carte versus more fully. And these are other questions which are good to ask, right? If we're doing our own vulnerability assessment, does your organization, do you know how your employee assistance program works with individuals at risk of suicide? What training do they have? Is this something which is included in their screening? And how can organizations plan this in advance? Right? It's not looking at it just like we look at other events. This is not necessarily an if, this is a when, right? The time to prepare, the time to have systems in place is before something happens. This came out of a larger quote, which I trimmed down for you, but it's to say managers have a significant role in creating the culture of mental health. You're positioned to identify when somebody's having overwhelming issues or may prompt warning for suicide, and you are in a position to intervene. That's good information, right? That's a good understanding, but how do we make this actionable? It doesn't, by knowing that position, it doesn't necessarily mean that the managers have the skills on what to do. So these are some of the some pieces of the guides that would be expanded on and shared, right? Having managers understand what warning signs are for suicide, what to do and how to reach out to individuals, and specifically what to say, right? These are the same types of things that are included in trainings, clinical trainings, right? How do we talk about suicide directly? Right? We don't use words like, "You're not thinking about doing anything silly, are you?" Right? You're not thinking about hurting yourself. We want to ask the question that we want the answer to, and communicate that clearly. So how do we use that language to be able to ask directly? It's always good when talking with someone, mention the notice, make it behavioral, right? Make it, maybe behavioral is a word that can imply areas of improvement, but it's to say, make it objective. Right? These are things that I noticed. I noticed that you've been coming in work late more often. I noticed that you're not as, you don't seem as happy these days. You've stopped, well, no, nobody's eating in the break, but I've noticed that you stopped eating your lunch in the break room. Whatever these are, is able to acknowledge the changes. Offering hope and offering the understanding of that this is something that's changed. I'm not the therapist, but I've noticed, I'm a supervisor, I'm a manager, I've noticed these things. There are resources for you, right? And how to encourage staff to take advantage of that. And also within the limits of confidentiality. And right, so we do not want to make promises that we can't keep, right? So we can't say whatever you tell me is going to stay here. We don't say that to our patients. We can't say it to a colleague either, right? But we want to protect their privacy as much as we can, because there are circumstances, right? We don't want to put ourselves into a situation that we find out there is an acute need or a crisis which is about to unfold, and be in a position that we are not have communicated that we wouldn't share anything. So these are, again, some things to reflect on for your organization and to answer the questions to have the answers to, which would be helpful in training your managers and how you would respond when including this information and communicating to staff, right? What is the access to counseling records? Are there any possibilities that diagnosis, including substance use, substance issues, can impact internal promotion? Is this a cost that is going to be taken on by the staff, the provider, and what becomes part of the record? Who will know? Who will be involved? So these are things which can be very real barriers to taking the steps towards accessing help. And then also, again, this comes back to what does the employee assistance program do? How do we even explain to if we're going to speak and encourage somebody to participate in treatment, we should have an understanding of what that is and what it would entail. Things when looking at how to roll this out, how do we do these types of trainings for staff? So the one and done, right? And this is oftentimes a pitfall of trainings. Even the best ones is that we come in and we do a training, and then everybody goes back to their busy schedules. We say, okay, this is really important. This is this new, really important thing. Everybody's getting this very special training. It's very important. The organizations even comes from the highest level of executive organizational-wide emails. This is this initiative that we're find very important, but it just sort of goes away, right? It has one, a big rollout, a red carpet, but then it doesn't have sustainability. It's not something which becomes part of the ongoing conversation. And so become part of the policies, become part of the workflows, become all of these other things. And so looking at what types of trainings, how is this going to be different or in content, in timing for existing employees versus during the onboarding process. And it's also to say one size does not fit all, right? And so how we talk about suicide and train staff in their particular roles can be very different. And this is not only in caring for each other, but also in the idea that it's everyone's role to know the warning signs, and within their role to be universally looking for patients who are at risk of suicide, right? And so this is, the front desk, always so critical. The people who answer the phones, these are so undervalued or underappreciated. The importance of the staff that answers the phones. They have such a critical role in being this first line of talking with people, and particularly, when somebody calling and canceling their appointments, right? And this helps when this is an ongoing relationship, when the patients are better known. But even in not in those circumstances, if somebody calls and cancels, you see that they've never missed an appointment, and they're canceling. Well, I'm not going to be coming back, or talking with particularly in a billing department or human resources. What they should be looking out for, and how those risk factors may present from who and how is different. To help avoid this type of one and done training, is how within an organization, rather than having an outside training that comes in and then doesn't have ongoing support, how could your organization find ways of having internal experts, internal people who can continue the training, and more than one, and because employees change over time. How do we get this to be a part of a resource that is supported and adaptable and ongoing, and then as well, what are the how are we going to ensure that each of the trainers are doing the same thing, right? And that they are maintaining to the standards of best practices and the methods in which we want to be communicating this information. Thinking about this in a modular training that can be combined with other key parts of somebody's role. So how do we relate this type of information? How do we embed this into other trainings which are already existing, like electronic medical records, right? Where is this located? How do we include risk of suicide? How do we look for warning signs? How do we communicate risk factors with care teams and share safety plans or access safety plans, and how those can be used? And ultimately, how are we measuring success of a training program? Once it's developed or before it's developed, this again comes back to practice change and adoption of new ways of doing things is more likely to be successful and accepted when it has outcomes. And so when we're able to say, this is what we're doing and this is how we're going to measure it, what would it look like to be successfully a training program for staff? And how are we going to measure it? So when making these plans, it's helpful to do a self-study in effect, right? These are all of the departments. These are the job titles. This is how many people have the different types of jobs. And knowing that these are not only the needs, but these are also the resources, right? And so this is how we tailor things to the different, tailor the trainings and the needs to fit the organization. And again, this also builds into the ability to engage senior leadership when we can quantify these things. We can justify this is what we're doing and why. We need this amount of time, we need this amount of trainers, because this is the amount of staff that we have, or this is across how many different sites, this is the timing which is involved, and what would be required to make this successful. And sometimes we get the question, well, why do I care if all my staff are trained? This kind of comes back to more of the a la carte, to say, well, why does my billing department need to be trained in suicide safer care? Why does my maintenance staff need to be trained in suicide safer care? Or human resources, and it can kind of go on from there. And it's to say that, this, again, coming back to the very first slide, the Swiss cheese, right? We need all, this is, how do we raise this to the level that says suicide deaths are preventable, right? What can we do that says we're doing, what is, or another way to look at it is to say, what is an acceptable number, right? What is okay? What is an acceptable number of suicide deaths within our system? And looking at it, hopefully the answer is 0, right? And they say, we want to do all we can to prevent this. And so by doing that, everyone needs to be involved. I had a story about training different staff. Well, I can say for certain. And again, I guess come back to the front desk being so critical, and when that they have alerted us when something and creating the environment in which they feel comfortable to act on their own within their role, right? To say, I was talking with this person, they canceled their appointments and it just didn't feel right. I'm concerned, right? And having that and having a way that communicates this in advance that says, this is what we want, right? And that a person doesn't get that there's a reinforcement of that this is a valuable use of time, right? I may need to not answer the next phone call because I really need to. I just need somebody to look at this, somebody else to look at this. So, when looking at a systematic approach, this not only is top down, but also bottom up. And when we say top down, it requires buy-in from executive leadership that says this is we are making a commitment to this from the highest level. Because whenever there's training, whenever there's changes, this is difficult. This is changing the status quo. This is requiring time. This is requiring funding, money, changing of how policies and procedures, and particularly in such a sensitive area, it's easy to, it makes it a lot more valuable and essential to successful adoption when there's a senior and executive support of this. But it's also something that can also be generated from the bottom up that says we are the front line, or we are the front line, and this is what we're seeing, right? This is what we're experiencing. This is what we're seeing, and there's a discrepancy. There's a gap. There's an education gap or a planning gap, and this is and we've done, and we found these things that is shown to work, right? And we've learned about these other programs that are doing these things. What's the pathway that I can advocate for this here? Differentiating this from a project or a program, these have start and ends. Programs have specific people that work on it, right? And that's not a systematic systems approach, right? Systems approach is this is something which is ongoing and involves everyone. Looking at it from a population approach, checking in on time here. Looking at things from a population approach, meaning within the organization, how do you or how can you address the needs and address risk from already known risk factors, right? Are there ways of going through the electronic health record and identifying everyone who has a history of depression, identifying people who are at increased risk? How do we do things from a population health approach and then able to measure that? The two populations also being staff and providers. Including this as part of the quality improvement, ongoing, continuous quality improvement. How do we look at this? How do we, although it's not a project or a program, how can we take pieces of it to continuously improve and investigate? Including this throughout all of the other systematic, systems-wide essential processes for care. Champions, and why do we need them, right? So, again, coming from a system implementation method, we want to find the people who are already doing this, right? The fact is there probably are, regardless of where the organization is, there are people who are at the cutting edge of this, who have either on their own or from past experience gotten the training. They're the ones who are asking these questions engaging them is going to be really valuable because they've already figured it out. These are the things which, this is the way that the workflow is supposed to be, but this is the way it has to be in order to do these other things. They've already figured it out, how it has to work at that site. And this is really valuable information and can easily, not isolate, but not getting the right word. But if from the organization comes up with this great new program, or this great new way of doing something, and we come to the site and we say, this is the great way that we're doing this, but there's somebody there who's already doing stuff that is not quite that way, it can be really invalidating and say, well, I've been doing this since, 20 years ago. We've been talking with people about suicide. Who are you to come in and tell me that this is the way that I'm doing it wrong? Nobody else is doing it in the first place, right? So how do we engage them from the very beginning? Because they have key information and people experience and also the trust and passion towards these topics. Specifically, again, this comes back into baking this into the workflows. You have to say exactly what is expected. To help this take root, I would say, what is a culture of wellness, right? And how do we, how are there ways of bringing discussion of suicide, not only for those who we are caring for, but also a environment which supports check-ins and for risk factors and vulnerability. How do we create this a part of the ongoing experience? Communicating it in a way which is front and center, right? How do we put this on the same information that we get for our benefits? How do we have access to say, this is a service that we have? There is a hotline that you can use, right? And this is put in with all of the formal information, right? In a way, communicating that suicide is something that is okay to talk about. This is part of our culture. Talking about suicide is okay, and this is something which we understand is uncomfortable but important. Offer education opportunities, right? Again, this is ways for people to get more involved, and this is get more involved, become champions, and learn more about it. Also key to identify times in which come to the very front and our need for intervention. These frequently come in different avenues through direct suicidal statements, Facebook posts, information from colleagues. Somebody calls and says, "Hey, don't let my roommate alone at lunchtime today." Right? We don't know where this information is going to come in. What is the method for interfering? I have a colleague who told me a story where there was not. This is actually kind of the next slide, but and how to include this in. And we don't know where this is going to come in. The information is going to come in, but it's so important to think about it before it happens, right? Not if it happens, before it happens. This is a true story that I heard from Verna, who is another expert and faculty member of Zero Suicide, and this was within her own organization that she was overseeing. Someone got a call, maybe that said this person is at risk. They made suicidal statements. The manager locked them in a closet. Yeah, if we were in person, I would hear gasps. I know you're muted. I hope you gasped. The manager locked the staff person in the closet until they could figure out what to do. This is, we have to give the person the benefit of the doubt. They were doing what they thought was the right thing to do at that time. but it didn't have to happen that way, right? And this comes back into the importance of having protocols and understanding what to do. Postvention, I can also just say is after an event has happened, right? And how do we make this? How can we learn from events of patient deaths, of staff death? How can we take this from a root cause analysis? How do we learn and grow from this? And how do we create a way of doing this which is categorically different than a review, right? And how do we learn from it without having those who are most involved feel that this is punitive, looking through a chart and saying, well, they missed their psychiatric appointment. Why didn't they get a call? The protocols that they get a call if they missed their appointment. How did this person fall? So this can really feel like it's punitive when ultimately there are ways of doing it that can learn from it. Well, why didn't it happen? Well, this was busy. I saw 15 people that day, and I'm usually scheduled for 12. The same thing happened the next day, right? So there's oftentimes, there are reasons that things don't happen, do or do not happen, right? And so that falls under root cause analysis. And how to include in postvention the involvement of friends, involvement of families, and having a mechanism and workflow for that, which fits into whatever requirements and standards are within the organization and community. One thing I could say, think about it before. Another story that I have, they had the human resources. So there was a person in the human resources department, and they identified that they were at risk for suicide. All of the human resource managers went and said, well, we know who we need to call. We need to call this person to find out what do we do next. Well, everybody went into the other room to find out what to do. They made a call. When they went back, the person was gone. Right. So this is this is the small things which can make such a big difference. Right. And so having as a result of not thinking in advance. As with most trainings, this is just a taste. This is most of the training is hopefully that you've learned some things, but even more, you've learned about things that you would like to learn more about. And so the education and this is not the end of a training. This is hopefully just actually setting you off to learn more about how your organizations can improve in the area of a systemic working with risk for overdose. And thank you for the amazing work that you do. We do have a few moments for questions, so I'd like to open it up. And I think we can also take a look to see if there are questions in the chat. Okay. Please feel free to unmute yourself. Questions, comments, stories. Okay, I saw a question that came in. Great. Thank you for discussing this very relevant topic. Great, thank you. Thank you for that. I'm glad that you found the training helpful. The question, will we be receiving a copy of this PowerPoint? Absolutely. We will make this available afterwards. I also know that the training is being recorded, but I don't know exactly the access to that as well. But most definitely, we can make the PowerPoint available. Yes, so great. A question around web-based training modules that we can recommend. Most definitely. So zerosuicide.com is a great resource. It depends a little bit on the role, again, right? So it's not like a one training fits all. There are some excellent trainings that is more clinically based, like ANSWER, Assessing and Managing Suicide Risk. That's a full-day training for mental health clinicians and primary care doctors and primary care settings, not just physicians, and how to assess and manage suicide risk. Very clinical and concrete. Many programs also encourage people to take ASSESS and Safe Talk. These are two other suicide trainings, which is more geared to less clinical staff, which may be more relevant to like the folks who are at the front desk, right? So that they feel more empowered and confident. I think there can be concerns about revealing one's issues with this as staff because of implications for human resources involvement. So I'm wondering, how would you recommend navigating that? It's a very good question. Thank you. You're absolutely right. I think this is the heart of it, that there is inherent barriers within healthcare that make it difficult. But this is also right. We could be talking about, I don't know, aviation control programs, right? Which I would imagine also to be a very stressful environment where it would be very shunned upon to be talking to express thoughts of suicide or mental health or substance use issues, right? And so it comes back to, I think, first knowing what the limits of confidentiality are. And because these are questions that are really common and understandable from staff. So to know within the organization who has access, when somebody reaches out for help, who has access to that information, and how does that, what implications can that have? I know some organizations, how does that affect their benefits? How could that affect their insurance? And so on. This is not only a challenge, but also because it's known, it is something that can be improved. I think knowledge is key. So I guess the simple answer is how to navigate it. First is to understand what the process is within the organization. And are there ways of making it more accessible and confidential? How do we make, and this might be things like including a hotline, right? And so making that more available so staff doesn't feel like they have to go to a manager as a gateway to get more help. How do we have this sign in the break room and as part of on the back of an employee ID card that says, just like we have a compliance hotline on the back of our, we also have a hotline for staff wellness, right? And so decreasing the people involved, I think would probably, in most circumstances, help. That's a great question. and I hope that the question on web-based training was answered. If my answer wasn't really spot on, I still stick with that zero suicide is an excellent hub of resources and the Suicide Prevention Research Council. So not only do they have trainings on their website, it's just an excellent guide and training materials and recommendations. Thank you so much for sharing this valuable information and guidance. It's so easy to overlook mental health for providers in the healthcare profession, as focus is constantly on others than internally. Thank you. Wow, we have a really long comment as well. Thank you, insightful. And some life experience with this. So thank you so much. You know, it's hard to find a room in which folks have not been personally affected by suicide. So I think the importance of this is knowledge and language, getting this out in the open and in ways that we can talk about it. And with the incoming tide, all boats rise. Thank you, Rick. Is he another? Oh, if you guys aren't going to cut me off, I'll keep talking. I can say there was a question that did come in. How, other than what was mentioned, how can healthcare professionals, including nurses, how can we offer support during the pandemic? I know that organizations are trying their best to do even small things. If there's ways of having a day where there's take-home lunches, and that saves these nurses and frontline staff some time when they go home. Those types of concrete resources can really go a long way. We are in a phase of this, which is past the heroic phase, right? There's a time in where people are banging pots, but we are in we are in the long haul for this, and for many people who have been working, the support and from neighbors, from friends, isn't the same, right? So how do we keep that going? How do we listen to them and ask them what can be helpful as well? 15-minute, organization to have 15 minutes a few times a week where they've actually hired somebody to do virtual meditation and movement exercises. It's just a small amount of time, but can make a really big difference. But I think it also it's so much more valuable when it comes from the staff, rather than being this is this idea that we had, right? Reach out to the staff and say, what can we do that can help you feel more supported and connected? And with that, I thank you all and have a wonderful day. I hope, and thank you for so many of your comments, and it's great to hear the feedback. So good luck, and keep doing the wonderful work that you're doing.